All right, everyone, welcome to the fifth workshop of STEMathonX 2.0. Today we're joined with Mr. Doe, an occupational therapist. Thank you so much for being here, Mr. Doe.
Thanks for having me here.
Yeah, so just as any other workshop, we're going to start off with some basic questions from Mahir and I, and then if the audience or any pre-submitted questions want to be asked, then we can go ahead and transition into that as well. So, Mr. Doe, do you want to start off by kind of explaining what an occupational therapist is, what their role is in the hospital, and all of that?
Yeah, hi, my name is Victor. I'm an occupational therapist. I've been one for 2 years so far, and my role as an occupational therapist is primarily in physical disabilities. There are different types of occupational therapists that have different types of roles depending on where you work and the type of setting you're in. But to essentially sum up what an occupational therapist is and what they do in general is that they are focused on being able to get people back to doing the occupations in their life. And that could mean a lot of things. Occupations or anything that's important to you that you have to do or want to do. And that could be as simple as being able to wake up in the morning, brush your teeth, get dressed, to things that are complex as driving, going to work, spending time with your family, going on vacation, painting, playing sports. It's basically anything in your life that you do. And depending on the type of therapist you are, who you work with, where you work at, you'll be different. You'll be dealing with getting people back to being independent, safe, and secure in doing all those things they have or want to do. And in my case, I work in physical disabilities. I work at a skilled nursing facility. So my goal is to get people who have been injured or ill going to get back to being independent, living at home, being without help, doing all the things they need to do to get back to their home safely, or at least being able to live as much of their life as fulfillingly as possible. And my population is mostly people who are older and the people who are more at risk, disabilities and illnesses and the like.
Yeah, so you mentioned that you work a lot with people, especially like people who are ill. So, especially during the COVID-19 pandemic, where it felt like almost everyone was getting ill, especially
Yeah,
in a nursing home, which you said that you spend a lot of time in, especially
yeah,
working there. Could you kind of impact how COVID-19 impacted your role?
yeah. It's interesting because on one hand, things aren't entirely different. On the other hand, it really changes how we have to approach things. On one hand, our role remains the same. Our goal is to focus on rehabilitation, get people moving, get people active and independent, because the risk of us not having a role when it comes to these times is that people are not getting the attention they need because of the fear of getting sick. And with that comes people getting weaker and weaker and weaker from not being able to leave their rooms, not able to move around as freely. So our goal remains the same in that we have to get in there and encourage people to move, work out, get back to living their daily lives, even though it's a bit different. The difference is, of course, because of COVID, that means we have to take more precautions. We try to take the same role, but we have to be more mindful of how close we are. The PPEs are a major factor. We have to take more precautions to make sure that the spread is contained and the like. And another thing that has changed for us is that we also have to take more of a role outside of our profession, in that because of how difficult things are, we're more proactive in helping out the other staff members and making sure that the patients are well taken care of, that the nurses and the CNAs aren't as overworked as they were before. So it encouraged us to take more of a proactive role as a member of the medical community, not just as therapists. And speaking in terms of my colleagues and my friends who work in other sectors, I know that most of my OT friends who work in, say, school settings and pediatric settings, their role has to change majorly in that they can no longer have those face-to-face, one-on-one interactions in person. And now a lot of the therapy has to be regulated online, which makes things much more difficult. It places you more in a teaching position as opposed to a more hands-on position, where you're working directly with patients. But in our case, when it comes to people who are already ill, who are already sick and injured, we can't really afford to have that distance from the patients and the people we're working with. So we just have to be more mindful and admittingly take more risks since we're right there in the middle of it all.
Yeah, so bouncing off the idea of COVID, I think medical professionals have probably been hit the hardest out of all jobs in like the industry. How's your day-to-day life looked recently?
Things have been getting a little better as of recently because more and more people are getting vaccinated and we're getting cleared by the state to have more activities and be able to have more freedom to move around. Before in the past, COVID impacted us in that, like I said, much more precautions, much more safety concerns, more proactivity in gowning up and being mindful of how we enter rooms, how we put on our PPEs, those kinds of things. Typically, though, day to day looks like I arrive at work, we are cleared for any types of symptoms, and daily life revolves mostly around being able to be receiving a set list of patients that we have to see every day, and it's typically patients that you're familiar with, that you've seen before, but that's not always the case. Sometimes you'll get patients that you've never met before, and especially in the hospital settings, the majority of the people you see aren't people you haven't met before. And life as a therapist is a lot of proactivity, improvising, and learning how to manage your time, because there isn't necessarily a set time in which you do anything. You're giving a list of patients that you're familiar with. You're familiar with their cases, what they like to do, what they have to do, and you plan out your day one patient at a time. So you don't necessarily set up a schedule. You arrive at the rooms, you see them, you address their issues, and you administer the treatment that's best for them, whatever that looks like. And typically at the end of the day, it's a stretch of documentation where you document what you did with them, how well they performed, and any changes in their behavior, their health, and their performance. So just to summarize that, it's being able to have a set list of patients, planning out your day, who you're going to see and what you're going to do, seeing them and being able to document what you did. And all this while being mindful of infection control, PPEs, and factoring in the people you need to talk to, the different staff members, in order to address further concerns, such as with the nurses or the doctors, in order to make sure they get proper care and proper treatment. And advocating for the patient, of course, that's always an important part, making sure that their needs are met outside of just therapy too.
Yeah, I agree. There's a lot of like precautions doctors have to take in anyone in the medical field. So
Yeah.
since therapy is known as like a profession that requires a lot of talking and communication,
Yeah.
has social distancing really affected the way you communicate during work? Like, have you had to do Zoom calls, or can you still talk face to face without like, how does that work?
Yeah. No, it hasn't really affected how I communicate with people. Like I said, in the skilled nursing facilities and also in the hospitals, we can't afford to have that distance. So we're still having face-to-face discussions, only at a distance with more precautions and more PPEs. And as I said before, my colleagues in school, in pediatric settings, working with kids, being face to face is not as crucial. So for them, they do have the face to face. They do have the online Zoom meetings and such, or phone calls and whatnot. For us, we have not changed how we communicate with patients, because we still have to be present in their daily lives.
Yeah, so just bouncing off of that, since, as a person in your profession, you have to still be around these people who could potentially have COVID. Has anyone dropped out of your job just because they don't want to take that risk?
Yeah, there have been, at least from my experience, in our rehab team, there have been two people who have dropped out. Understandably, it's unfortunate, but they have. The rest of us stuck together pretty well, actually, shockingly well. I can't say the same for the nursing staff, unfortunately. There was a lot of chaos when a lot of the nursing staff did drop out. And that's why I mentioned before that we had to take more proactive role outside of our profession because we were so severely understaffed and more people getting sick that we had to take more action being able to help because of how many people dropped out. In terms of rehab, the fortunate thing is I believe morale was still fairly high for us because we have a really good director who led the charge, who stood up for the patients and really wanted to do her part to help. And we followed suit because she's a really great leader and we really wanted to help support her. So fortunately, I can confidently say that not a lot of people in our department dropped. I can't say the same for the rest, but for our department, we stayed pretty close in solidarity when it came to dealing with this pandemic and being able to perform our roles in the midst of this crisis.
Yeah, so you mentioned that your department like is very strong and very strong-willed. So do
Yeah.
you work with only people in your department or do you work with other people in other departments? Kind of like a branching out organization.
Yeah, we definitely branch out. Primarily as an OT, I work primarily with the physical therapists. And in the case of a physical disability settings, our roles typically overlap when it comes to what we do to get them more independent and stronger. Our philosophies differ, but in terms of treatments and how we approach things, we usually work hand in hand, especially when it comes to some of the more physically impaired patients. It usually takes the two of us, both physical and occupational therapy, to work together in order to tackle a problem and help a patient get the support that they need, especially for safety concerns. When it comes to safety, sometimes one person is not enough to ensure that something doesn't happen in case of a fall or lack of balance or unstable medical condition. Branching out from that, we work closely with the doctors, social workers, nurses, and the CNA staff to not only to coordinate treatment and coordinate scheduling, but also to advocate for the patient. And I believe that's an unspoken part of therapy that doesn't really get addressed enough, is that we are typically the middlemen and the biggest advocate for the patients because, again, philosophies differ between medical professionals, despite the fact that we're working in the same place. And one of our biggest roles is making sure that patients are being heard, that their needs are being addressed. And so it's a lot of going out to talk to the doctors, talk to the nurses, have them be made aware of what's going on, what their needs is, any changes in their condition. Because we work so closely and so often with the patients, we're typically familiar with their day-to-day changes. So if anything comes up, we're usually the first to notice that something might be up and you might want to check that out. And talking with the social worker is a really big part of our role because the social worker helps coordinate being able to make the shift from being in therapy at this facility to going home. And so we have to talk closely to the social worker, make sure that they're aware of how the patients come along, what kind of services they need, or when they might be ready to go home. And so when it comes to treatments, yeah, we work mostly with physical therapists. When it comes to planning ahead, we branch out and work with everyone else in the interdisciplinary team.
Yeah, it looks like therapy requires a lot of communication skills to build trust with your patients.
Yeah.
So now we're going to step back a little bit on the timeline. So do you think you could talk about the path you took to reach where you are? Like, let's say starting from high school and all the way up to now. Did you have any difficulties along the way?
There are a few difficulties, mostly because of expectations when it comes to family. But I started in high school. I took an interest in psychology when I was in high school, and I didn't know what kind of profession, but I know I wanted to be in a profession where I was able to use my skills in psychology to be able to communicate and address people's concerns and needs and help them in some way. And before that point, I had a lot of exposure to the medical field, especially therapy, because of my own family. My father had about 4 strokes growing up, so we were always in and out of the hospital, in and out of nursing homes. So I was familiar with the professions. But at the time, going into college, my family wanted me to go into computer science and the sort, but I wasn't really that dedicated to working in computer science. So I want to go into something that involves helping people, working face to face direct with people. And that was when I was reintroduced to therapy, occupational therapy specifically, because it really fit the bill of what I wanted to do. And occupational therapy was more appealing to me than physical therapy because it really emphasizes a lot more creativity in the type of treatments you do, and in terms of the people you work with. Physical therapy is mostly focused on the physical form, disability, pain, and fitness and the sort. Occupational therapists branch out into working with getting people back to work, working with kids to get them back to school, um, hand therapy, designing new devices to help people live their best life, to be more independent. I like that freedom and creativity, and it had more emphasis on mental health. So college was mostly working on being able to do your basic requirements, mostly in biology, physics, anatomy, and psychology and the sort. And it admittedly was not very fun, especially physics. All the core sciences need to be addressed. You have to take classes in all of them. And there was one requirement that is a little interesting. It's strange, but it was a lot of fun. But most schools require you to have, for your requirement, be able to take part in some kind of physical art, like not painting, but like ceramics or pottery making or something that involves working with your hands to create something, which I found really interesting. At the time, it didn't really make a lot of sense to me, but like going into it, OT worked a lot of their hands, especially going to hand therapy. There's a lot of crafting there too. So it was an interesting requirement. So in case anyone wants to go into OT, that's something you have to keep in mind. You'll need some skill in working with your hands for art. Going into grad school, I personally liked grad school. I know a lot of people didn't, though. Apparently, it was very stressful. It's just a lot of work, a lot of it's just constant emphasis of physiology and anatomy and a lot of memorization, especially when it comes to medicine and diagnosis and treatments and the sorts. I personally liked it because it was just for me, it was a college experience. You're with a lot of peers who are like you, and personally I got along with most of them. So you have this family of people who stick with you to the very end. And that was personally a more enjoyable part, but hearing my friends talk about it is very challenging, it's stressful, and it takes up a lot of your time. But once you get through it, you're out of the woodwork, and then it's a matter of studying for your board exam, and that's admittedly also not very fun. It's months and months of studying because you pay a hefty sum to take the test, and if you fail the test to get your board license, you have to take it again in about a month later, and preferably you don't want to have to take it twice. So it's a lot of cramming, a lot of studying, preparing for the board exam. But once you do it and you're through, you're out of the woodwork, you're done, and you're free to practice the profession. So it's a long journey. From beginning to end, I would say it's about, let's see, 4 years for undergrad, 2 to 3 if you want a master's, 4 years if you want to do if you want to get your doctorate in occupational therapy. And this factors in the year that you have to do for your internships to your field work, where you go out and spend 3 months in 2 different locations. So 6 months total, I believe, getting experience in a hands-on real life scenario. And the settings differ depending on where your school places you. And you have to pass both of those after school before you're free to take the board exams. And those have their own challenges too, because you're thrown into a real life setting for your first time. So you're not entirely confident about what you're doing, but it gets easier over time.
So since you spent like many years in college studying all these different techniques, do you think you could describe like some of the treatments you use to help your patients? And also like, how do you know if a treatment is working? And if it's not, like, what do you do next?
Let's see, treatment options. Let's see, it's treatment is primarily, uh, it's based on the philosophy of doing. For me in school, they really emphasize if you want someone to get better at doing something, have them do it. So, so it's a lot of just doing things. If you want someone to walk, again, you have to really practice being able to get to them to the point where they're walking. And once they're strong enough to be able to take a few steps, you keep doing it. You progress slowly. You're working on a hierarchy of needs. You want to build up the foundation for their strength, and then build up from there and work slowly up the proverbial ladder to get them to the point where, okay, if they weren't able to do something before, you can work up to them being able to do it, and then refine it so they get better. So it's a lot of doing, a lot of fitness, moving around, get them just to be active, and it's important to be consistent in being active. So when it comes to that, there's no bells and whistles. When it comes to specific diagnosis, such as strokes or spinal cord injury, and sciatica or frozen shoulders, all those sorts of things, those do require more specific treatments when it comes to addressing their pain, or getting them better and better. And once those are addressed, it really goes back to being able to, once they're at a threshold, you just build up from there. Once they've overcome their specific difficulties, then you just work on having them just perform the activity and actions that you want them to do, and then refine it from there. Get them better at it, stronger at it, more precise, have them be able to do it for longer. And sorry, what was the second half of the question?
Oh yeah, I asked that. So say like a treatment is not working, then like what do you do next?
Let's see, what do I do then? When it comes, not everything works, and sometimes you don't know until you look back, look at the results, how far they've come, and realize, okay, nothing's really changing until then. Either you try a different approach, or you switch to a different therapist, and that's the reality of the situation. Sometimes it takes a different therapist, and I've seen that before, where sometimes the reality is you don't work well with every single patient. And I've seen patients that just haven't progressed very much in the time I've been with them, switch to a different therapist, and suddenly they're doing just so much better, because maybe it's their demeanor, maybe it's their approach, they know something you don't, or they just have a different type of personality that gels well. Usually the biggest reason why a person isn't getting any better, from my experience, is that they are not invested enough to do it. It takes consistency and motivation and drive for someone to get better. Sometimes it really depends on your personality, as opposed to the specific medical knowledge you have. Because everyone, for the most part, is on the same page when it comes to medical knowledge, but not the same page when it comes to the type of person you are. And it's a really big factor when it comes to getting someone better, to get better. So you can always try switching to a different therapist. Or like I said, sometimes it is just the technique you're using. You'll have to switch gears, try a different type of technique, ask your colleagues for their opinion on the matter, and just pivot and keep trying.
Yeah, so I'm going to transition into some pre-submitted questions, and I want to do that because
Okay.
there's a question that kind of relates to what you were just talking about.
Yeah.
It's a special case type question in the sense that this anonymous user is asking, what's the most interesting patient you'd had to deal with, and what kind of procedures did you do with them?
More interesting patient. Let's see. Let's see. One of the most interesting one was this 7 feet tall, 300-pound man. And he was a particularly tough one because he is just a giant. And getting him better was a challenge because he has a degenerative disease that just gets progressively worse over time. It has a happy ending, but the guy starting off, oh man, he needed 4 people to lift up and take maximum of 8 steps. Nowadays, he is fully independent, which is absolute shock. And for him, it required a lot of investment. First of all, like I said before, it's a lot of just doing, a lot of doing. We needed him to walk, so we kept walking. Luckily, at that time, I was working with a physical therapist who was very physically strong. So between the two of us, we could get him standing, and it was just a matter over time having him do more of that, more standing, and then taking more steps, and then going for farther distances, and in order to slowly build up his strength. On top of that, it was a lot of modification too. We start off getting him specific splints for his feet because he has foot drop, so his feet drag. He can't lift them very well. He doesn't really feel his feet, so we got specific splints to help him walk better. Just to start off. Nowadays, he doesn't really need them, but starting off, we use them in order to get him more stable when he's walking. We modified his wheelchair to fit his body better and be of a specific height, so it's easier for him to stand up and rise, so we could slowly, gradually build up the strength in his legs in order for him to move better. And then over time, as he needed less help to walk, I switched gears to help address more dynamic motions because walking isn't the end all be all for things. You know, everyone walks in context of something. So I wanted him to be more independent and be able to move through his room, do his daily activities, go to the bathroom, take a shower, reach above to grab stuff from the fridge or the shelf. So a lot of dynamic movement, twisting, turning, reaching behind, above him, that sort of stuff, being offset of his balance, getting out of his comfort zone. And then just encouraging him to be more proactive in his health. Like I said before, motivation is the biggest thing. You can't always be waiting around for the therapist to help you. You have to take charge in your own life if you want to go back to your own life. So encourage him to be more proactive and moving around, setting up his room in a way that he can have access to his wheelchair, access to the bathroom, the commode, access to his closet, so that he wouldn't need to ask for help. I wanted him to be more proactive and be able to take care of himself. And that requires you to not only analyze the patient, but also his living standards, the environment that he's in. So it's set up in a way to really support him being able to live his best life. And just over time, he did take advantage. He used the strength to take advantage of his situation. He did more for himself. Nowadays, he's walking on his own. He's doing things on his own. He is more proactive in being independent. He goes out, talks to his family, talks to his friends, and he doesn't require people to always be around and taking care of him. That's always their end goal. Our end goal is not to make people stronger necessarily, or even independent, but to make them be able to live the life that they want to, whatever that looks like, in whatever context that is. It just depends on the person, right? So he was tough, challenging, really proud of how far he's come. He's become a good friend of ours now, so a lot to be proud of there.
Yeah, for sure. Working with all kinds of big people, little people, all sorts of people must be a big responsibility for all occupational therapists. So it seems like we're reaching the end of our time. So I wanted to end off with one last pre-submitted question. And
Yeah.
do you have any advice for people who are thinking about entering the occupational therapy field or just therapy in general?
Any advice? I would say that it's a profession that doesn't get enough attention, and it can be stressful. It can be stressful at times, but it's incredibly rewarding. So advice for people going in, I would say if you are empathetic and you really want to make a difference and think about the people in the context of themselves, like it's a definite go-to for people who really wants to make a difference. And chances are you'll find something that you'll like in this profession. So if you want to go for it, really you should go for it, because you really do listen to the lives of the people you're with. You really want to understand that them and the things they do and what makes them unique. And you'll find a passion in this profession that you'll like, whether it's working with kids or adults or working with prosthesis or even research. I know a therapist who works training horses in order to get people working with horses in order to increase their physical capabilities. I've seen there are therapists that work in ergonomics. There's one therapist in Texas who works with Microsoft in order to help create the adaptive controller to help kids be able to play video games, because playing video games is important to kids, being able to have fun with their friends. So there's something for everybody. So if you're passionate about making a difference in people's lives, go for it, push for it, really invest yourself in it. And it's worth it in the long run, even if it does get tough sometimes. So just keep your eyes on the prize, I'd say. And don't give up. Never give up. That's always our biggest advice to our patients too. So just go through with it. Keep pushing until you make it through.
Yeah, so hopefully all the future occupational therapists tuning in at home took some notes on that. Thank you so much for your time, Mr. Doe. We do hope to hear from you again.
All right, thanks for
And if
having me.
anyone else has any questions, then you can feel free to send it to us, and we can probably let Mr. Doe know on his own time.
Gotcha. All right then. Thank you.
All right, bye.
Bye. See you around.